Great. Well, thank you, Mr. Richmond. And I now yield to Ms. Herrera Beutler for her question.
I'll make it brief. Thank you, Madam Chair. A couple things you mentioned, Ms. Trudell, that kind of sparked my interest with regard to penalties. Did I understand you right when you were saying that for hospitals versus group practices, there were different? I know they went into effect on different implementation dates, and I know Medicaid is withheld from the penalty side. Did I hear you say that hospitals are exempt? What did, at the very beginning, what did?
No, hospitals and eligible professionals are both subject to the same penalty at the same time.
Okay. And in terms of small group or solo practitioners, I mean, a hospital system is going to have a lot more wherewithal to implement an EHR, period. A small group practitioner or a solo provider in a rural area who's not a critical access hospital, right? I know we've propped that up, is going to have a hard time making this investment, particularly if they are the only family physician or OB in a region. And I've met some of those doctors. How are you taking extra precaution and care and assistance? Because I heard you talk about a lot of the goal is to assist with some of those and recognizing, especially if we're talking about a family doc, it's an aging population, right? Not very many people are going back into this practice, and that's a whole other issue. But some of them I've met have said, you know what, I can run my practice. I've figured this out. I've got enough problems with med-mal and everything else. Don't bring this my way. How are you overcoming that? And in a non, penalty way?
First, I'd like to talk a little bit about the outreach that we have been doing, which is very much geared toward reaching exactly those kinds of providers. As an example, our 10 regional offices over the past 9 months have conducted over 400 events, more than half of which were either targeted specifically to or included significant quantities of small and rural physicians to try to explain to them what the program is, what the advantages are of it, how to take advantage of it, and what some of the other tools and resources, including the regional extension centers, are available to them so that at least they have the ability to fully and completely assess the opportunity and make a decision as to whether or not they want to take advantage of it.
What kind of feedback, and this is a question I'll ask of the next panel as well because they're the docs doing this, what kind of feedback have you had from them? What kind of uptake, positive, negative?
We're actually getting good uptake. We've been doing some trending over the period of the last year, and we are getting a sense that a large percentage, I would say over 70% of the physician practices that we're talking to actually have exhibited some interest and are thinking about it.
So when they have problems, right, with a company that was certified by one of the 6, certification agencies, or what is their recourse?
Let me talk about the supports that we're offering. Dr. Brule was one of the first providers to get their payments for meaningful use last week. And she spoke about working with the Regional Extension Center in Kansas, where she is a family practice and a practitioner in a small practice. And she talked about how when she first saw started adopting the systems and saw the list of requirements, that she was daunted by that, but that the Extension Center helped give her an understanding of what is really behind the meaningful use, practical steps on how to achieve it, help with project management. And she gave one example about saying there was quality measures around colonoscopies, and she thought she was doing a pretty good job with colonoscopies that can be life-saving if they identify cancers early on and they can be removed. And she said when she actually had the information system to look within her data, she was only doing it about 40% of the time. And she was really upset. But then the technology helped her make a list of all the patients, reach out to them, have reminders in the system. Those are all part of meaningful use. And she reported that she wasn't satisfied yet, but things were better. She was at 84% now. And she said, I would never go back to being on paper. So I think what we have in our favor is that providers, even though the road is hard, providers like Chairwoman Elmer's husband, who has gone through the hard work, would never go back to using paper-based systems. And it is rewarding because it is in line with what they want to do as physicians and nurses.
And really quickly, if they have a not just a bump in filling out the paperwork or jumping through the hoop or meeting the quality measure, if they have a real substantive problem with the IT provider, or I mean, do they have recourse?
Yes, the regional extension centers. Let me give the example. Georgia and Massachusetts regional extension centers are working with banks to help their providers get loans for the hardware and software. Very practical, addressing a real need that they have. The extension center in LA are doing project management, helping them do every phase of project management of going from implementation to meaningful use, and are working directly with the vendors to identify problems and mitigate them when they have it. Ohio REC has developed a comprehensive needs assessment that goes through and helps the practices identify what are some of the weak points that they need and gaps and barriers, and working with the provider to address any issues before they go live rather than trying to fix things afterwards. So those are all examples of practical ways that the extension centers in all across America are working with the 70,000 providers to help them address any problems they might have and move forward productively.
Thank you.